Every single year, Medicare spends well over $6 billion on durable medical equipment, prosthetics, orthotics, and supplies. According to CMS payment data, roughly 8 out of every 100 of those claims contain a coding problem that affects payment. That creates a baseline error rate of 7.6% across the board. This chart compares that 7.6% baseline to the improper payment rate for manual wheelchairs, which sits at an elevated 30.5%. And for lumbar-sacral orthoses, the improper payment rate jumps even further, reaching 54.4%. Translated to pure dollars, that is $28.1 million in projected improper payments for manual wheelchairs and $47.8 million for spinal orthoses in a single year. When practice leaders see denial rates this high, they often assume they are losing a debate with the payer over clinical ambiguity or patient medical necessity. The CMS data directly contradicts that assumption. These high-value claims are largely failing because of basic, systemic breakdowns in administrative execution and coding, not because the equipment was clinically inappropriate. When auditors review these denied claims, they consistently trace the failure back to missing paperwork. This area graph breaks down the exact root causes of those rejections. For manual wheelchairs, insufficient documentation accounted for 79.7% of all improper payments. For patient lifts, that paperwork gap expands to cause 91.8% of the errors. The CMS Comprehensive Error Rate Testing Task Force specifically flags missing or incomplete proof of delivery documents as a primary culprit across these categories. CMS maintains a strict compliance mandate requiring that proof of delivery documentation be kept for 7 years, regardless of delivery method. Securing that documentation requires tight coordination between clinical staff, the billing team, and the ordering provider. When any link in that communication chain breaks, the document is lost. Practices regularly forfeit legitimate revenue on necessary clinical orders simply because administrative teams lack the bandwidth to secure a single delivery receipt. Proper documentation is only the first hurdle. Over 40% of Medicare Part B claims include at least one HCPCS Level II code. Every DME claim requires the correct modifier to process. This code component communicates whether equipment is rented with an option to purchase, new, used, or if medical necessity documentation is actively on file. Industry data shows that consistently applying the right modifier to the right item under specific payer rules can reduce a practice's denial rate by 20%. However, these rules are not static. CMS updates HCPCS Level II codes 4 times a year. During a single recent update cycle, CMS added 6 entirely new HCPCS codes just for hypoglossal nerve neurostimulators. If a billing team misses one code change during a quarterly update, claims begin rejecting immediately. By the time they trace the rejection back to the new code, several weeks of claims may require complete reworking. Navigating these quarterly updates requires dedicated attention. A general administrative hire cannot reliably execute this level of specialty coding while balancing front office tasks. Practices recognize they need credentialed specialists to manage this workflow, but national staffing data reveals why so few successfully build that team internally. This chart reflects polling from medical group leaders. 34% identified medical coders as the single most difficult revenue cycle role to hire. Finding a coder with credentials and DME billing experience is rare, and keeping them is harder. Business operations support staff carry an annual turnover rate of 33.3%, onboarding and lost productivity. When a specialist exits, the practice enters a gap period. It typically takes 8 to 12 weeks to train a replacement on the specific EMR, payer mix, and documentation workflows. During those transition months, first-pass resolution metrics drop and the accounts receivable queue expands. Attempting to solve high-volume DME coding errors by perpetually hiring and retraining an in-house team is an operationally inefficient cycle that drains capital. To break this cycle, high-volume practices are shifting away from internal hiring, moving HCPCS coding to an outsourced AI-augmented infrastructure. A platform like Staffingly deploys AAPC and AHIMA-credentialed specialists who log directly into your existing EMR ecosystem to execute the daily workflow. These specialists operate on top of an intelligent routing system. The software uses predictive workload management to distribute claim volume across the team, preventing backlogs during high-volume periods. Before a claim leaves the system, automated workflow checks flag missing modifiers or incomplete proof of delivery documents. The technology manages the repetitive quality control in the background, allowing the human specialists to apply their credentialed expertise strictly to the coding decisions that require clinical judgment. This entire data environment operates under strict security frameworks, including HIPAA, SOC 2 Type 2, ISO 27001, and HITRUS. Combining credentialed coders with aggressive software auditing allows practices to maintain coding error rates below 1%. Beyond accuracy, the decision to deploy this model is driven by pure economics. Hiring an in-house coder requires a $55,000 to $75,000 salary before benefits and turnover costs. Staffingly provides a dedicated specialist for $399 weekly, or about $20,748 annually. This yields immediate savings of $34,000 to $54,000 per seat. The entire credential team completes training on your specific payer mix and goes live within 14 days. Throughput, accuracy, turnaround time, and return on investment are compiled into weekly performance metric dashboards, designed specifically for a CFO or practice owner to review in minutes. Following a pilot period, engagements are month to month. Practices can scale their team size up or down with 30 days notice, eliminating long-term contractual risk. Capturing your share of the $6 billion DME market does not require hiring better clinicians. Instead, it requires upgrading your entire revenue engine to a dedicated, specialized model that executes the administrative paperwork flawlessly every single time. Visit staffingly.com/demo or call 800-489-5877 to launch your risk-free pilot program today.